about CRO because a lot of common factors are there. So I request Dr. Giri to please go ahead with this talk on CRO and have a discussion.
So thank you. Am I audible? Thank you, Mahesh, Professor Atul, Lalit Verma, Ajit, Nati, and my dear friends. I will be talking on management of central retinal vein occlusion, and I have made this into a case-based presentation. I made it into a case-based presentation, and I would be, after each case, I would try and give some message based on my experience and also based on the available evidence in randomized trials. So as we all know, the terminologies non-ischemic, ischemic, and hemi-retinal vein occlusion. These are the three conditions that I will be focusing on during my talk. In the management of central retinal vein occlusion, anti-VEGF therapy, when, how, and why, laser photocoagulation, when and how, what is the role of intravitreal steroids, and a few points on the management of neovascular glaucoma, although that's sometimes managed by the glaucoma specialist too. This is my first case. This is a 61-year-old female who presented with a defective vision in the right eye. She was a patient with primary open-angle glaucoma, and she was a pseudophakic in the eye that was affected with immature cataract in the other eye. Now, this is a classic picture of a central retinal vein occlusion, a non-ischemic CRVO, where we see the dilatation and toxicity of the retinal veins with blot and flame-shaped hemorrhages. And the OCT at that time did not show any evidence of increase in the CMT, so the patient was educated to come for regular follow-up. However, the patient reported within a few days with a drop in visual acuity, so it was counting fingers 3 meters, a suspicious RAPD. IOP was a little bit on the borderline, and she had significant increase in the central macular thickness. And at this moment, the patient received 1 dose of intravitreal ranibizumab, and within a month, there was a complete resolution of the edema. So in patients with retinal vein occlusion, at least in my practice, I do not do a loading dose regimen or a regimen based on the old cruise trial, where in the initial 6 months, patient received their 6 monthly injections, but I treat them on a PRN basis right from the beginning, but try to keep them under regular follow-up. So patient had a recurrence after 3 months, for which again, she received a single dose of ranibizumab. The use of ranibizumab is based on multiple RCT trials. Why I highlighted this case is the importance of understanding the existence of primary open-angle glaucoma, of another risk factor for central retinal vein occlusion. And it's very important for us to examine the fellow eye to look for any evidence of undetected glaucoma. This is very important because many years ago, we had presented a paper in the All India Ophthalmological Society where we reported a significant incidence of undetected primary POAG, especially normal tension glaucoma in patients with central retinal vein occlusion. This is my second case. This is again a female patient, 64 years, blind in one eye due to central retinal vein occlusion, neovascular glaucoma, defective vision in the other eye, already treated elsewhere with the intravitreal dexamethasone implant, and also has received laser photocoagulation. This was the picture when she first came to us, and she had significant increase in the central macular thickness. Patient was treated with ranibizumab initially because patient, after the dose of the Ozurdex, 2 doses of Ozurdex elsewhere, had increase in intraocular pressure, and she was a little concerned about that particular complication. So she was treated on a PRN basis, but you can see here, patient requires very frequent injections, about once in 6 weeks at least. At this moment of time, the patient I shifted to a treat and extend regimen because of the frequent need of intravitreal, ranibizumab. And this is very important because if frequent increase in the retinal thickness slowly results in damage to the outer layers of the retina and affects the final visual outcome. So with a treat and extend regimen, I could stretch her maximum to about 8 weeks, and she is still under my follow-up. And recently I shifted the patient to aflibercept, which gives a little longer duration of quiescence as far as this particular patient is concerned. Therefore, what are the options in eyes that require frequent interventions? One is either we switch to another anti-VEGF, look for intravitreal dexamethasone, and also do a fundus fluorescein angiography. And if there is peripheral retinal ischemia, probably laser photocoagulation also will help. This is my third case. This is a patient, 64-year-old female, who presented with bilateral central retinal vein occlusion, again having diabetes and hypertension. And we should always remember that diabetes, hypertension, obesity, all of them put together, or any one of these diseases, along with dyslipidemia, are important risk factors, and we need to look into these factors when we treat these patients. So for this patient, again, had received a dexamethasone implant elsewhere, and this is the picture when she first came and saw me. Her visual acuity in the right eye was reasonably good because of the normal CMT. The other eye had a significant increase in central macular thickness. This patient I treated with multiple doses of DEXA implant in both the eyes. And the reason why I did that is basically when you have bilateral disease, management is difficult. At least the patient gets a longer period of quiescence as far as the disease is concerned. But in spite of 2 or 3 injections of dexamethasone implant, she continued to have recurrence at shorter intervals, about 2.5 to 3 months. At this moment of time, I switched her. I did a fundus fluorescein angiography. There was no evidence of any peripheral ischemia and wide-angle fluorescein angiogram. I shifted her to ranibizumab, but that was a poor responder. And subsequently, she was on bevacizumab, which gave about 6 to 8 weeks of quiescence. And she continued to have bevacizumab in both the eyes. And most important message I want to give is that in these sort of patients, treat these patients only if you find visual acuity improvement, because if the visual acuity is not improving because of ischemia or because of the significant damage to the outer retinal layers, I don't think really there's any purpose in again and again giving intravitreal injections. So she was treated on a bevacizumab in both the eyes, and subsequently she had a phaco, IOL, and Osidex. Therefore, at the final visit, just before the lockdown last year, that was the last visit, she came like this. She was going to Canada, and therefore I put her on a bilateral DEXA implant. I've not seen her since then. Therefore, bilateral CRVO becomes a challenge as far as the management is concerned. What is the role of intravitreal steroids? In my practice, I give intravitreal steroids as a primary treatment and treatment name in certain specific situations where patients have had strokes, multiple cardiac events, etc., where probably there's a risk of giving intravitreal anti-VEGF agents. Otherwise, I do not give steroids as a primary care in a treatment name patients, because I feel that ischemia is the key factor in venous occlusion, and anti-VEGF probably helps and probably even delays or prevents or reduces the incidence of neovascular glaucoma, because in the CRUISE trial, in the long-term retained study, they have shown that basically patients who are on frequent anti-VEGF injections and in the compared to the sham group, the incidence of neovascular glaucoma was definitely less. And I do fundus fluorescein angiography in patients who require frequent injections or in eyes with ischemic CRVO after the hemorrhages are recently absorbed to look for significant capillary closure. This is my 4th case. This is again a 57-year-old patient diagnosed elsewhere with associated primary open-angle glaucoma. This patient had already received 12 injections of ranibizumab. In this particular patient, I put the patient after initial fundus fluorescein angiography. I did it initially itself because he has already been treated elsewhere with multiple injections. But again, I did not see much of an closure. I put this patient on aflibercept because I thought that he has already had ranibizumab. I put the patient on aflibercept based on the available evidence, and I could stretch him about 3 to 4 months because this patient was coming to see me from abroad, and he wanted a longer period of quiescence, and aflibercept gave me about 3.5 to 4 months, or probably 4.5 months of quiescence as far as this particular case is concerned. Therefore, aflibercept is definitely an option in patients with central retinal vein occlusion, especially in situations where there is a frequent need for intravitreal injections, and probably this may give a longer period of quiescence as far as the management is concerned. FFA and CRVO, when and why, I have already explained that basically not to do it in the initial stage. It's necessary to describe, find out the amount, if the element of ischemia in a patient with ischemic central retinal vein occlusion, and probably pan-retinal photocoagulation, especially in eyes with global ischemia, where there is a very high risk of neovascular glaucoma, is indicate laser photocoagulation. I do it in all cases of significant peripheral ischemia where I feel there's a significant risk of neovascular glaucoma. I advise because these are patients who may not come for regular follow-up, and finally they may land to us with with advanced neovascular glaucoma and a blinding complication. I also do it as a first line of treatment in neovascular glaucoma. This is my 6th case, a one-eyed patient who came to us very recently during the pandemic. And this patient again was blind in one eye. In the other eye, he came to us with a central retinal vein occlusion, significant increase in macular thickness, and he had a 636/18 vision. He improved to 620 with the injection, but then the patient reported vascular glaucoma, which was treated with intravitreal injection, pan-retinal photocoagulation, and subsequently, since the patient had useful vision, he received an AGV implant. This is my last review. And basically, Hemicentral basically also was treated the same way. So in summarizing, basically, I would like to say that basically in CRVO, we need to monitor disease activity with OCT and visual acuity on a regular basis. Anti-VEGF is the standard of care. Decision to treat should be based on visual acuity outcomes, and neovascular glaucoma is a potential blinding complication. Thank you all for your kind attention, and I'm sorry I crossed the time limit.
Thank you, Dr. Giri, for a wonderful lucid presentation. So we'll discuss these two presentations, and there is a question for Dr. Lalit Verma in the Q&A box from Dr. Ghosh, who has asked, in treatment of BRVO, do we need loading dose of anti-VEGF even if the macular edema subsides after one injection?
No, I don't think so, because it's not like ARMD where we loading dose or IPCV. In vascular disease, BRVO, specifically in BRVO, I am not a fan of giving loading dose. What I would do is, after, if the patient has responded, I would perform an angiography just to rule out any ischemia, signal ischemia, and keep the patient under follow-up.
Yeah, that was one thing which is common to Dr. Lalit and Dr. Giri were mentioning, is that they'll do an FFA, look for peripheral areas of capillary non-perfusion, and do laser. But then studies have shown that would this be to decrease the macular edema, or would this be for the risk of neovascular process?
So in my, as far as BRV is concerned, I think it does help not only from the point of view of neovascularization, but if you kill those ischemic areas or make hypoxia into anoxia, this does help to reduce the VEGF production, and it may put an end to injection or limit the number of injections.
But the studies have shown otherwise, isn't it, Dr. Lalit?
Yeah, but I don't know. My personal experience says, whenever I've lasered a BRVO which was having an ischemia, and so for months and months and years, they may not require injections. I don't know what Giri has in mind.
Well, I think, Mahesh, we can take it like this. See, there are certain patients with BRVO also who need very frequent injections. And in fact, I remember one of my patients who used to come to me very regularly. But so finally, a fluorescein angiogram, and he received a laser photocoagulation to the ischemic retina. And again, after that, 1 or 2 injections. But after that, he is okay for a long period of time. Now, we really do not know whether it's the natural course. But then these are patients who, over a period of 2 years, have received about 7 to 14, around 10 to 14 injections. And basically, then the question arises, they ask what else can be done? So in such a situation, I think if there is definite ischemia, I think there is no harm done. It may not, I don't say that it's going to work in every case, but there is no harm done. We are not doing any harm to these patients.
Lalit has a more simplified BRVO, but tributary BRVO also certain times it becomes so chronic, it don't respond so easily. So that message should go across to everyone that you cannot take BRVO easy. It's a chronic disease, and certain times it requires more injections as much as CRVO. And peripheral ischemia definitely to be seen. It is not like full sector or full PRP will do, but limited PRP and the peripheral area where the ischemic areas are there, that definitely helps in reduction of the macular edema. It is not only for avoiding the neovascularization, both CRVO as well as BR. So we should be very focused in identifying these areas of ischemia, and then targeted laser should be done.
No, just to add on, just one scenario. I have both for Lalit and Dr. Giridhar. That vision, there is a patient vision maintaining somewhere between 6/9, 6/12 fluctuate. We have enough amount of laser done. We have multiple injections going on. Now he sort of stabilizes every 3 months, one injection. But the moment you exceed that, vision goes down from 6/9 to 6/12. You can make out very thin, flimsy membrane. There is like a ARM-like thing. There is no PVD yet. Now you are neither here nor there, and the time comes like where you would like to stop the treatment. Even if you delay, it doesn't reduce beyond 6/12. But if you give injection, it comes back to 6/9. This is going on last 2.5 years. And obviously this patient, I won't suggest, because there's a minimal traction, I won't suggest vitrectomy in this scenario. I mean, how you are going to deal with this scenario?
So I have a patient like this. He is an engineer by profession, and his right eye, you see, I have lasered sector laser only, and his vision is 6/9, 6/12 parts. But the way I follow that patient is, I have done serial OCTs every 4 to 6 weeks, and that that edema is constant. There's some edema, but it's constant, irrespective of whether I give injection or not. This cystic edema, which is slightly parafoveal, is constant. So I'm not doing anything except following him up.
Yeah, similar scenario. Or you isolated one single cyst sitting right at the fovea, nothing happens whether you inject or do not inject.
Actually, that single cyst will never respond.
Never, yeah.
Agree.
Will never respond. So
Yeah, that's
That's
another thing we
what
need to understand.
Pramod said. If there is a epiretinal membrane,
Yeah.
especially even if it is a mild traction, it's always better to go for vitrectomy. These cases I have found that post-operatively it somehow stabilizes.
But
You do not go for repeated injections.
my criteria of doing a vitrectomy in a 6/9 vision is patient has to ask for it or beg for
Agree.
it.
Obviously.
I will not. You see, these membranes
Obviously,
may look simpler.
I agree with Dr. Lalit. So I'll be
These
hesitant to
can
go
be
in.
very difficult vitrectomies, I agree.
Yeah.
And yes, what we need to understand is like BRO is like the treatment may go on for years together, 3 years, 4 years, and even subsequently some of these patients may continuously need treatment. So in the interest of time, we'll